A very good morning, ladies and gentlemen. We are about 4 minutes out. And so I'd just like to take this opportunity to thank you very much for coming in today for the session. And again, just a gentle housekeeping reminder, if you could kindly keep your video off as well as mute your sound, that would be lovely. Thank you so much. I notice everyone has kind of done that already. And then, of course, taking the opportunity to thank as well Dr. Kanna for sparing his Saturday morning and more importantly, putting aside patient time to spend some time with the rest of us to provide some very important insights on different, perhaps a very cutting edge area of cancer. And we're very fortunate to be able to have Dr. Kanna with us today. So I think we're about 10:58, I think. So I'm just going to steal that time and start ahead. And what we will do is then as people just join us, you can continue to follow the session. Please don't forget that the session is recorded. We'll put it on YouTube at the end of the day. And for those who are doctors or nurses, there is an e-certificate that will be provided for nurses or all other healthcare professionals. For doctors, you have CME points already approved. And please fill in your details right here after the session. So without further ado, please allow me to introduce our speaker today for the session of the SKD, the SK Dharmalingam series. And this is the third of the installment of this series, which is really named after our co-founder. I'm also actually delighted to be able to share that Dr. Kanna will also have many interesting, I suppose, anecdotes or to share as he knew and worked with Dr. Dharmalingam personally as well over a number of years. And so we're doubly actually fortunate to be able to have Dr. Kanna with us today. Please allow me to introduce Dr. Kanna. Actually, he really needs no introduction, but for some of us who maybe are not very familiar with the oncology field in Malaysia, please allow me to provide an introduction. Dr. Kanna, or as we fondly call him, his full name is Dr. Kananathan, is a consultant medical oncologist. He has been with Nilai Medical Centre since its inception, actually, and he is currently the medical director of Nilai Medical Centre, as well as the head of its clinical research unit. Dr. Kanna graduated from University of Malaya and is a fellow of the Royal College of Physicians, as well as a member of the Academy of Medicine. And he's also attached to ESMO as well. ESMO is the European Society of Medical Oncology. Now, what is interesting and really makes Dr. Kanna unique in amongst many aspects in the Malaysian oncology kind of landscape is the fact that he is very, very active in running clinical trials. So I would say he's the cutting edge of the knife, if you could put it. So a lot of very like how to say new and exciting clinical trials run in oncology are part of what Dr. Kanna does in a day-to-day role, and he has worked in more than 40 multi-center clinical trials. And very interestingly, also as perhaps a point of note, Dr. Kanna is one of the few individual clinical trialists here who's actually got audited and certified by the US FDA, which is quite a big achievement as well for a country like Malaysia. Dr. Kanna, of course, continues to be very active in publishing his research. It's more than 100 publications, and continues to speak and present at a lot of international, national, scientific congresses as well. So without further ado, please allow me to turn the session over to Dr. Kanna, who will speak to us today. Just a small reminder before Dr. Kanna comes on that to kind of mute your videos and your audio as well. And then we will, once the session comes to the first kind of little break, you can put up your questions, and then Dr. Kanna will be, I think, very happy to kind of answer them as they come along. So please allow me to turn the screen over to Dr. Kanna. Thank you, Doctor.
Yeah. Thank you very much, Dr. Murali, for the kind words. And I would like to thank National Cancer Society. It's a privilege, actually, today to talk in S.K. Dharmalingam's series lecture. I mean, many of us would not have known him. I mean, he's a giant, a doyen in oncology in our country. And he's done a lot of things. And in preparation for this lecture, I thought at least a few words on Dato Dharma would be apt. And when we try to Google on him, I think National Cancer Society should document the work done by Dato Dharma, you know, Murali, because it is it's something that people can forget. Now, this is the what do you call a quick from Sinaran. Sinaran's edition in 2006, they wrote about Dato Dharma's contribution because he just passed away on the 17th of July, 2006. But before that, let us look at a little bit on the history about cancer. It was in 1600 BC, first time cancer was described by the Egyptians, ancient Egyptians, but only in 460 BC, Hippocrates talked about karkinos, a Greek word for crab, to describe what looked like today is cancer. And in 25 BC, Celsus translated karkinos into the word cancer. And in the 2nd century AD, Galen described the word oncos. This was the process, a long, tedious process. And as pioneers, it's a difficult task. And we today sit on the shoulders of the giants before us for the work they have done. And Dato Dharmalingam was what you call a visionary, a giant in his time, you know, in the 60s, because very few of us will ever realize when Dato Dharma first set up the Institute of what you call oncology and radiotherapy and hospital, the KL General Hospital in the late 60s. It was one of the top 20 cancer centers in the world because at that time, people were only treating with cobalt in most parts. And he introduced what we call today the, what you call the radiotherapy, which is linear accelerator-based radiotherapy, which brings the treatment for cancer more precise. And we were probably the only one, you know, maybe Japan was the what you call, may have it, but even Singapore didn't have these machines at that time. And we owe it to Dato Dharma to set the tone and train the next generation of oncologists who have rolled up. And today, the topic today is about what we call as the personalized cancer management using the, basically I'll be going through the, what you call, overview of targeted therapy. How do we identify candidates and genomics? Actually today, this topic is very interesting and what do you call, state-of-the-art treatment strategy, because we want to personalize cancer treatment, but that comes with a cost. Now, when we look back at this screen, is what was described by Weinberg in Cell 2011. Weinberg, Professor Weinberg is a professor of Ludwig in MIT, and the kind of work they have done there in cancer is cutting edge. So there are 6 qualities of a cancer cell. First of all, this abnormal cancer cell resists cell death. Then they have an ability, after resisting cell death, they are able to proliferate. And while proliferating, they are also learning to evade growth suppressors. And at the same time, they are activating invasion, metastasis. They are enabling replicative immortality and inducing angiogenesis. This was first described 9 years ago from Weinberg's laboratory about what we call the hallmark of cancer cells, of a cancer cell. And for us to cure cancer is we are hoping all patients could be surgically treated to remove the cancer. Of course, the disclaimers are for nasopharyngeal carcinoma, lymphoma, and leukemias, etc. Surgery is not the treatment of choice. But once surgery is done, we have to consider things like chemotherapy, radiation therapy, bone marrow therapy, etc. Immunotherapy is now a new kind of a thing, which is also part of the targeted therapy. Interventional radiology has also become more prominent, and of course, clinical trials. It's important for patients who are receiving cancer treatment that we have what you call clinical trials on board, especially phase 1 trials, where we can help patients who have run out of options to try off new drugs, which may help, not necessarily will help, but at least give them an option. Okay. Now, targeted therapy has increased slowly. When we first started, we looked at targeted therapies, like we are looking at the hormonal therapies, which are very, very targeted in breast cancer. Then we are looking at small molecules, antibodies, and vaccines. So these are the options that are available in targeted therapy. But at the end of my lecture, this is in the early days, but in the end of the lecture, we have got 4 categories of targeted therapy. This is a cartoon that was in Times in 2010, where they were talking about targeted. Where are we targeting and what are we trying to do? So, So in this cartoon, you can see removing the tumor mask is one way. Make the tumor less productive is a second. Stack up the immune system deck is the third way, and build the right immune cells the fourth way. And this is where the the main thing of trying to customize treatment for cancer patients is in it. Let me just run quickly through a case history. There are a few case histories in this presentation just to reflect. This is a patient, 34-year-old lawyer, all right? She was diagnosed to have breast cancer on the 15th of December, 2008. She had stage 1 breast cancer. She was just married and she was, planning to have a family, but she refuses to have any adjuvant therapy. And in December 2011, while coming back from South Africa, she had a severe, when the plane landed, she had a severe backache. And she was taken in straight to a hospital in KL, and there they diagnosed she had bone metastasis. She was given radiotherapy and advised to have chemotherapy in the months to come. But patient came to see me, and I decided to start the patient on Tamoxifen. It's a hormonal therapy, and this Tamoxifen helped this patient up to the March of 2014. So it's a good about 2.5 years. And in March of 2014, as you can see on the CT scan on the upper right part of the slide, the pelvic, she got horrendous pelvic mass tumors, which we will call as the Kuchenberg in the classical description of the tumor dropping down into the pelvis. And our gynae oncologist managed to do a total abdominal hysterectomy and bilateral salpingo-oophorectomy and remove the tumor. And God was kind to her, I will say, not that is our brilliance, but God is kind to her. She was started on Femara 2.5 milligrams. That's the second generation of hormone, which is a kind of a target. And if you can look at the report, pathological report of this patient, which clearly states that the diagnosis, left ovarian mass with fallopian tube metastasis, carcinoma, incompatible with breast primary. And this patient is still on Femara, and it's a remarkable 12 years journey for her. Of course, She's working actively, right? But early this year, the CT scan is the one that was done is in April of 2002. You can see she was supposed to come in February, but she kept on postponing, and she came on. And then, though the pelvis looks clear, there was a spot in the liver that worried us all. Because for me, I just feel we are controlling the disease. The disease will pop up, but it's a question of when. So we had biopsied that thing under our interventional radiologist, and the report came back as negative for tumor, but I was still not happy. 2 months down the line, we did a PET scan, and happy to say that the patient is clear of cancer. I mean, this is a patient with a stage 4 disease, a young patient, 34 years old, breast cancer. That itself carries a bad prognosis. All right, she has not touched chemotherapy, and she just took 2 hormonal therapies, and I hope she will remain well. Now, let us talk about tamoxifen. That's what I will describe as an accidental drug. Tamoxifen was first developed by Arthur Walpole, who was in ICI. I mean, you know, things have changed a lot. Kodak was producing cameras, and I was asking my son, what is Kodak doing today? And he said they have gone into pharmaceutical. They are in the vaccine for the COVID. So ICI, which produced tamoxifen, is now not, I'm not sure what are they, but they have now, tamoxifen is already a generic product, but the originals are produced by AstraZeneca. So anyway, tamoxifen was actually produced as a morning after contraceptive. That was the aim of tamoxifen. Okay, but Arthur Walpole continued to investigate this, and he had a lot of issues, patent issues. So from 1950s to 1962, Dora Richardson, the chemist at ICI, finally managed to synthesize tamoxifen. And let me just go back to this. So tamoxifen is actually a selective estrogen receptor modulator. It is very selective, very targeted to the estrogen receptor, selective modulator. So it has got an anti-estrogenic effect on the breast, but it got a proliferative effect on the endometrium. And the prodrug, as called the effinoxin, is the one that is 100 times affinity for the ER receptor. So, coming back to this, it's also found by Juda's group in Harvard in the, in the 70s, that tamoxifen has got anti-proliferative anti-angiogenesis activity. So there was, the first study was done on the, they call it the golden retriever called Navy. And Navy had been, I suppose they induced some kind of cancer onto the Navy to run this test with a cocktail of celecoxib, which we have, doxycycline, which we have, and tamoxifen, and used it, and they found that the tumor disappeared on Navy. And today, the anti-angiogenesis agents are a long list of them. Now, coming to the HER2 story, making of the Herceptin, it was the work of, again, Weinberg's laboratory. Remember, I was talking about Weinberg in MIT. It was the Weinberg's laboratory. Weinberg is actually a biologist. His laboratory in 1982 identified the HER2 receptor. But in 1986, Genentech, who is a scientist, had to identify the protein. So Weinberg identified the gene, Alex Ulrich of Genentech identified the protein. And in 1989, while they are still languishing, until a dumb luck, they described it, of a mother of a senior Genentech vice president was diagnosed with breast cancer, just like that. One man flipped the switch on the HER2 research, and there went on the whole process of HER2 development, which is a very, very interesting story of how drugs took time to develop. So HER2 went through the process, And in 1998, Herceptin is approved by FDA for the treatment of metastatic breast cancer. This is a targeted therapy for patients who what you call exhibit HER2 amplification, will benefit by taking Herceptin, which is beyond doubt in metastatic breast cancer. But as it moved on, today HER2 found its place in adjuvant setting. That means post-surgery, if a patient has got HER2 expression, then the research is saying that patient will benefit by using Herceptin. But in my slides to come, I will describe cases of how and when. It's not, science is not absolute. That's all I can say, all right? So in 2007, Lapatinib came into the picture. It's an oral. 2012, we have Pertuzumab, and now we have the latest generation. So this is the complicated cartoon of showing how the HER2 family, what do you call, when they are unchecked, will lead to cancer recurrence. So now targeted therapy is a major modality of treatment. What does targeted therapy do is to block the growth of cancer cells by interfering with specific targets which are needed in the carcinogenesis and the tumor growth, rather than by simply interfering with the rapid cell division. So today, as it stands, there are 4 categories of them. They call them the small molecules, the small molecule drug conjugates, the serine kinase inhibitors, and the monoclonal antibody. Let me take you through. So we have gone through Herceptin, what do you call, Tamoxifen, Herceptin. But before this, there was another drug in between coming as what they call the magic bullet. That's called a Imatinib for chronic myeloid leukemias. And it found a new indication in what you call gastrointestinal stromal tumor. But we'll talk about what the oncologists like me see. Okay, so now comes the new era whereby the first study of IDEAL, where they're using ERASA in a patients with what you call non-small cell lung cancer. Those days when someone gets non-small cell lung cancer, if 100 people are here with stage 4 non-small cell lung cancer, 50 people will not cross 7 months. 35 people will not cross 1 year, and less than 10 people will cross 2 years. That has been the statistics, and not much improvement was seen there. But today, lung cancer has become like a chronic disorder, like diabetes, because there are so many modalities thanks to this targeted therapy and what you call immunotherapy, etc. Okay, but this is the breaking work. So they collected in both sides of the what you call Pacific. The Pacific. Yeah. In Japan and in America, they used this ERASA versus best supportive care in a phase 2. Phase 2 means patients after phase 1, they found some kind of improve, what do you call, patient can benefit maybe, so they want to try in a larger group of patients. So when they used this in phase 2, they found that people who took ERASA in both sides of the continents were improving symptomatically and feeling good. So AstraZeneca was very proud of it. So they went on to do what you call the ESUR, ERASA survival evaluation in lung cancer, which Nilai Medical Centre was one of the sites that this study was done. And in this study, what they found is that the patients that took these medications actually did not as, or probably even worse than the best supportive care. So that was really an upsetting moment for the company, AstraZeneca, because they said, what happened? Why is it that this phase 2 showed such promising results? People at the brink of death, they call it the Lazarus effect. You start them, the next day they are up, which I have seen myself in some of the very terminally ill patients. in lung cancer, when we blindly give them gefitinib they describe this as a Lazarus effect. You all could Google that and see that. Such great response, but when they evaluated this, they found that there was no survival benefit. But some of them went to the drawing board and realized that certain group of patients, ladies, non-smokers, Asian population, in that subgroup of the ESL population, they found that these patients actually benefited by using ERASA, by doubling the survival, overall survival. So then the people decided to go to the drawing board, because we were in the development of ERASA usage way back in 2003. We used it as compassionate use. So we were involved in all this work, so I knew every moment of it. Then they went to the drawing board and then they decided, okay, where is this? This is how. So it looks at a certain targets. Then they went to the lab and then they found what is the benefit. That is when they finally got the EGFR mutation at the codon 19 and 20, and then they started selecting patients rather than giving them blunderbuss therapy. And everything changed ever since that. And in a phase 3 in Talent, which we were also involved, where they used ilotinib in combination with cisplatin and with gemcitabine and this is a triple therapy. This was in 2007, where Tasiva, which is the equivalent to ERASA, but produced by Roche, was quite confident that triple therapy will work. And this also was a negative result, once again. So they found that triple therapy using ilotinib with cisplatin and gemcitabine did not improve survival when they compared with cisplatin and gemcitabine alone. So that is when the guys in the early 2000s realized there is more to it than just giving treatment, but to find the target. That is the thing that took the, the scientists to a different level. So this is what was described, the EGFR mutation. EGFR is an endothelial growth factor receptor. When the receptor is stimulated, it gives an order through the mechanism, as you can see, the enzymatic pathway called tyrosine kinase, and it informs the cell, the nucleus, the DNA to replicate. And they replicate well, they replicate bad cells. They also give blood growth receptor, blood vessel formation. And they also increase the morbidity of these cancer cells to run and also cause a kind of protection against radiotherapy. This was described in Cancer Research in 2000 by Harari and Huang, who were doing the work on this area, but from then onwards. So I would like to bring into this picture of the patient which I was telling you all about, which we had put on a clinical trial as well in this hospital. This is a 65-year-old Malay gentleman. He had stage 4 lung cancer. The chest X-ray on May 2012 is on the left, and that was a chest X-ray after about 24 months on the medication, and he went on to live for 5 years. But he had to go on, once the disease started progressing, he had to go on to another mode of therapy. You see, when this targeted therapy, there is something like when a patient sees me in the clinic and we want to start the targeted therapy, there are a lot of things that go in our mind. First of all, this targeted therapy, when the patient asks, how long do I take? The answer is, I will say, I do not know. You have to take it until there is no improvement and your disease gets worse. Unlike chemotherapy, we will tell patients with lung cancer, you need 4 to 6 cycles of chemotherapy in the old days. But then with the advent of Alimta, then there came something as called a maintenance therapy. But in targeted therapy, there is no such thing as 6 months, 1 year. There are people who have taken ERASA for 5 years. So in targeted therapy, that's the drawback. What I'm trying to say is that cost will become an issue. So molecular landscape in solid tumors are very complex, and there are a lot of targets. And for example, in the lung cancer population, we can see that EGFR mutation occurs in about 7 to 10%. But in Asian population, it is about 30%. That is why when they did the ESL study, they found the Asian ladies, non-smokers, did very well compared to the rest of their counterparts. That's where there's a higher number of mutation, EGFR mutation in the Asian population. So these are other kinds of targets they call the small molecule. Remember I was telling you about Gleevec, or what you call imitinib. This is a blockbuster drug that actually changed the molecular DNA of the BCR in the chronic myeloid leukemia. So the treatment, which actually it was like curing the diseases in chronic myeloid leukemia. So this is a long list of medications, small molecules. And there are more targeted therapies on the pipeline. And I think the last chemotherapy that I hear that has come out was eribulin. And after that, I don't hear any more new chemotherapies coming out. And I will be very frank with you guys that I can't even remember the long list of drugs. And my colleague as well acknowledges some of the drugs we can't even, pronounce, or so tongue twisting when we talk about these new drugs. So the list is very long, okay? And there are targeted therapies. These are small molecules, as I said, we talked about earlier, the Tamoxifen, that's the oldest of the lot. And the new generations are things like the P133K inhibitors, which are undergoing clinical trial. Some more long list of drugs. Afatinib is something that is used for stomach cancer, breast cancer, and CDK inhibitors, which are already available for breast cancer. Antibodies, okay. Antibodies, the most, we talked about the antibody earlier, that is Herceptin, it's okay, that's the earliest, way back in 1980s it was developed. But today, I think with the technology they have, they are able to develop and produce the drugs much faster than the rest. So this is the long list of monoclonal antibodies, and some of these like pembrolizumab, which is now the first immunotherapy. They link it under the immunotherapy, but it's a monoclonal antibody. It works on the immune system. Rituximab is also, it's a very long, old medicine, but it has been here for maybe 20 over years, used for Hodgkin's B-cell lymphoma. And trastuzumab is earlier, we have talked about it. Cetuximab is used, again, is an EGFR growth factor receptor inhibitor, used first in colorectal cancers, but now has found its role in head and neck cancers. Panitumumab is also an EGFR mutation receptor, which we were one of the sites doing this study versus best supportive care in colorectal cancers in the year 2000. Bevacizumab, that is or what we call as Avastin, a very well-established anti-angiogenesis. Okay, this is a concept where tumor is starting to grow. That is number one. The cancer cells multiply and grow in a tumor, and the tumor releases certain VEGF proteins. And this is a protein that makes more blood vessels grow into the tumor. And with the more blood vessels grow into the tumor, the hungry tumor takes more blood and more nutrition into its cells, and they grow bigger and bigger. That's a very nice concept. So Avastin, which is bevacizumab, was first approved in in year 2000 for colorectal in Malaysia. Then they got a second indication for lung. Then they went on to have indications in in breast. And in the breast cancer study, we were also one of the sites when we used it as a third-line therapy in Avastin in breast cancer. And the list grows with time: ovary, glioblastoma, multiforme, and liver. And I'm happy to say today there are 2 new medications which are called biosimilars to Avastin that is waiting for registration. Why is this very important? They reduce the cost. Biosimilar means they are about the same, but not exactly the same. And they get special approvals to run trials before, it's a long process, as you can see from the historical Herceptin, how many years it takes. But today, with this, with the new changes in how things are done, they are able to churn out faster. So we had done we were involved in some of the biosimilars for Avastin in lung and breast, and it will be soon available in this country, because 1 month of Avastin in a private setup will cost about 20,000. And how long? We all remember I said that Avastin we don't have a time frame. We use it until the disease progresses. So that is a lot. That is one of the biggest issues in health financing when we are talking about targeted therapy. This is what we call the checkpoint inhibitor. Checkpoint inhibitor is part of targeted, which is part of immunotherapy. So you can see the cancer cell learns to develop a kind of protein that covers itself so that our immune system is not able to recognize this abnormal cancer cell lurking in the midst. So Pembro and nivolumab, and of course there's a long list of new drugs which are coming out, seek out this protein, this layer, denude them for the immune system to kill those cells. But the disclaimer is that our immune system also needs to be healthy. How do we keep our immune system healthy? We need nutrition, we need exercise, we need proper mental status. So it's just not drugs. It's just not drugs. It's a whole set of gamut of things that is needed to get the best response. Just for example, the 38-year-old lady who has developed the meds in 2011 and now is 9 years down the line, she has not touched chemotherapy and a PET scan is clear. It's more to it, that's what I'm saying, Now, let me go through a case of a patient, 42-year-old lady with stage 4 malignant melanoma of the vulva. As you can see on the PET scan, she had tumor on the left lower hip around the lymph nodes, which is about 9 to 10 centimeters. Of course, affected a uterus all the way down, went up, and there are spots in the liver, in the neck, etc. And this lady came to me on January of 2019. She was referred for therapy. Pembrolizumab is indicated for malignant melanoma stage 4 as a single agent therapy. The dose of pembrolizumab is 200 milligrams per injection. And by the studies, patient must take it 3 weeks once. This patient had got a limitation. Her insurance only provides her with 80,000 a year. So Pembro, I would require, cost of Pembro would require 20,000 per cycle. So the company gives 100 milligrams, the patient buys 100 milligrams for 20,000 and another 100 milligrams, the company gives free of charge to make it 200. So after a lot of discussion with her, she took my suggestion of taking 100 milligrams, and I was really hoping that it would really work, and it worked for her. 100 milligrams. So one cycle she buy, the next cycle she gets free. One cycle she buy, the next cycle. So she managed to pull all the way up to the cycle 11, 9th of January 2020. She went to do a PET scan, which showed the lungs was clear, the neck was clear, the liver showed some activity, and as you can see here, the tumor size on PET before she started treatment, 9.2, 7.3, 5.8, had come to the ametabolic necrotic nodules at 4.4 and 5.3, and there was slight uptake in this. Then this was a PET scan done on January of 2019. So she took a free cycle 12, 27 of February 2020, and with COVID ravaging through our what do you call with the COVID pandemic, she also decided to take a break from treatment, and more so is because of her finances, you know. And she returned back to see me on the 23rd of July, where she had clearly progressed. I mean, in my experience of treating patients with stage 4 multiple melanoma with DTIC, day 1 to day 4 or day 5, if we have 100 plus today, by the 3rd month, people will develop brain metastasis. And by the 7th or 8th month, they would have passed away. This patient had a remarkable journey on this new medication, and you know, that is why this is the problem of targeted stroke checkpoint inhibitors. There is limitations we have, and that's what I wanted to share, you know. Now let me take you to a patient of mine. It's a 67-year-old lady. She was operated on 1st of August 2016. She had left-sided breast cancer, T2N3M0, stage 3C. She came and saw me for a consultation. Later, she moved on to another hospital, and in that hospital, they gave her 6-TCH, that is Taxotere, carboplatin, Herceptin, and they continued with Herceptin, 17 cycles. They did the radiotherapy. And when they did the PET on the end of the 23rd of December, she had relapsed in the lungs. And this is a patient, ER/PR negative, HER2 3+. So what treatment she received was the best treatment in the world that she could receive. Yet, while on Herceptin, 1 month later, when they did a CT scan, PET scan for her, she had lung metastasis, and then she decided that she will come, she's worried, so she wanted to be closer to be treated in Negeri Sembilan, so she came to Nilai, back again. So I basically continued on what she was on, something called a substitute for Herceptin. When a person progresses, we start the patient on azotrastuzumab. Azotrastuzumab per cycle is about 20,000. So after 3 cycles, spending 60,000, we did a CT scan for her, her disease progressed. So on the 1st of August, 2018, her disease progressed. Genomic studies is something that we have to think about. Okay, because you see, HER2 testing is a genomic testing done in the laboratory, and it's found that she was HER2 positive. Yeah, but despite giving the HER2 therapy, Herceptin, in the adjuvant setting, she developed a metastasis. And when we went on to second to HER2 therapy, she's disease progressed. So this is a patient which I'm trying to share with you all, showing that the treatment she has received is right, yet it is not. So that is why medicine is not an absolute science. It's very, very difficult for us to really draw the line, but we have to go back to the evidence. So what we did is that one of the sons are very smart. So he suggested, doctor, to me, why don't we do genomic studies? I said, that's a wonderful idea. Genomic studies, we sent over to Taiwan. It costs 18,000. It's not covered by the insurance. What do? You can't ask me to write an insurance form that your mother has, but to what do you call, get the genomic studies. You have to come out of your pocket, and the patient's family agreed. So they went on, they did the genomic studies. And this patient had you can see the gene alteration here, PIK3CA, which is very dominant in the in her, what you call, genomics of a cancer cell, that we were advised, that I was advised by the team in Taiwan, that why don't we try Afinitor? You see, Afinitor is approved to be used on ER/PR HER2 negative patient. ER/PR positive HER2 negative patient who have progressed. But in this patient, it's an ER/PR negative HER2 positive patient. So after a lot of discussion, family was receptive to try Afinitor, which I started on 10 milligrams. But after 1 month of that, she came in with sepsis. We admitted her. She was stuck in the hospital for about 2 weeks. We restarted her on 5 milligrams. And this patient, I'm happy to say, had managed to have 1 year of disease stabilization with Afinitor. So what I'd like to draw here then, whether the science has said ER/PR positive, HER2 negative, once they have failed the standard treatment, you can start Afinitor with Femara. But in this patient, it's an ER/PR negative, HER2 positive lady who failed miserably on HER2 therapy. And we have to start on Afinitor. So what I like to, why am I saying this, bringing up this case is that the science may be there, but things can be different, right? So anyway, this patient developed a pleural effusion, and we tapped her, and we went back to the drawing boards, discussed with the family, and then we started on a Lapatinib. Lapatinib is an oral H2 block, Herceptin, anti-Herceptin therapy, and a weekly paclitaxel, and that bought her another 6 months. And she came back, a very active lady who came back suddenly with an altered behavior, and we found that she had brain metastasis. She started on radiotherapy, and after that I told the family, let us give her a drug holiday. But unfortunately, she returned back to me on 1st of July with a progressive difficulty of breathing, and we had to tap her lungs, and now she is on a weekly gemcitabine therapy, which is a 6 lines of treatment. Now, I like to draw back, there is more to it in cancer treatment. This is a patient of mine, LYT. She is 60 years old currently, but when she was diagnosed, that was in 2013, 26th of June 2013, she was a 3C, ER/PR and HER2 positive patient. And she was enrolled in a multi-center clinical trial. This is the trial, which is, they were looking at not on the chemotherapy, they were looking at the supportive therapy, which I was audited by FDA, that Dr. Murali described earlier. It was a FDA audit because we were the first site in Asia to recruit the patient, and we had 9 patients in the trial. And they thought, I think it's time we go and check this site. So they came here. FDA came here they are looking at the processes, the SOPs, the famous SOPs. SOPs followed, is the protocol deviated, is the reporting system right, just to check, yeah? And they chose 4 sites for this FDA audit, and Nilai was one of the sites. But I want to draw back to this is that she, after finishing an adjuvant treatment with the supportive medication, she was in a big dilemma because she's a well-informed patient with well-informed children, whether she should take Herceptin as an adjuvant for 1 year. She's on ERPR treatment, that is for Tamoxifen, but Herceptin. And that lady was driving herself crazy because she had not enough funds. And finally, they decided not to have. So she didn't receive Herceptin as an adjuvant, only continued on Tamoxifen. And happy to say that in the last follow-up, she's clear of disease. And I always like to tickle her by saying that, you know, it's not the treatment, it's all about the mind that matters. You know, you must be positive. You shouldn't, if Herceptin, you can afford it, that is fine. But if you cannot, don't worry. You know, there's always somebody taking care of us up there. Okay, this is our survival results in breast cancer. HPMRS audited us, and we can see that we have a comparable rates. And I would like to say that when HPMRS audited us, they asked us, why is that our usage of Herceptin in adjuvant, our usage of Herceptin in metastatic disease is not an issue, we use it. But Herceptin in adjuvant is something that is not affordable in majority of patients if they didn't have that in the early days. But today we have what you call a biosimilar Herceptin, which has brought the cost down. But it doesn't mean FAC is not good. FAC is good. A lot of my patients were on FAC. A lot of patients of Dr. Chandra, Dr. Silva were all on FAC. So it's not to say all treatment is no good. All treatment is still good. But if you can afford the best, why not? There is a very interesting thing that I would like to describe before the EGFR in lung cancer, which is something that was they've done the small molecules. But the Cubans have developed an EGFR vaccine. That means if we go back to our chart here, this thing, they develop a vaccine to destroy this receptor. Okay? So the Cubans in Cuba, they have only one line of chemotherapy for lung cancer for reasons best known. Okay? So they developed this vaccine, and this vaccine actually revolutionized the treatment for lung cancer, which we were also involved in this clinical trial. This is a 54-year-old lady who comes from what they call Sabah. She had 2 months of hemoptysis and severe loss of weight and appetite. She was a non-smoker. So she had reduced air entry into the what they call middle and lower zones on the left side. And a CT scan done in Sabah showed a lesion which is 9 by 5.8 by 7.2. So when she came to us, I saw her, and she was not interested in ERASA. She wanted chemotherapy because she wanted to, what they call, make sure that she just had enough resources. So she finished the chemotherapy. And by the time she finished 6 cycles of chemotherapy, her tumor regressed from 9 to 7. Then we consolidated her with concurrent chemoradiotherapy, and she responded very well. And this patient went on to enter the EGFR vaccine study, and she finished 18 cycles of that study. And on the 18th cycle, this is continuously every month she needs to be vaccinated, but on the 18th cycle, for some odd reason, she developed an anaphylactic reaction, and she was so frightened, and she withdrew consent from continuing on the trial. But I am happy to say that today, that is 2020, that is close to 13 years, this lady with stage 3B lung cancer is still alive in Sandakan, and is very happy that she has, but she also did other things. She took her vitamins, and she took all kinds of this one to supplement. So it's not to say, you know, but whatever said and done, we are quite happy that, you know, this vaccine has really worked. And Finally, I would like to say that tailored therapy or personalized medicine is the way forward. And traditional one-size-fits approach, which was the standard of care for the last 30 years, is something that we have to do away if we can. Okay? And today, the knowledge of disease, the biology, the genetics are playing such major role that clinical decisions will be gowned. Thank you.
Okay, so thank you very much, Doctor. That was really an interesting presentation, and I think what was really good is he kept the best for the last. I think the vaccine is really brought on quite a lot of excitement. I'm going to ask Doctor if you're okay to take questions for a bit.
And
there's some
yeah.
Sure. So, ladies and gentlemen, if you have questions, please kind of feel free to type it into the chat. Doctor, I already have one from, I think, Dr. Sherlyn. She asks, for the HER2 patient just now with brain mets and the PI3K mutation, why was immunotherapy not considered for the patient?
Right. This patient, in the genomic studies, they have already showed she had microsatellite stable cancer. For immunotherapy like Pembro to be used, it's important we have microsatellite instability, because this is an option that I wanted to consider for her. But when I discussed this further, because she is microsatellite stable, we couldn't give her immunotherapy in the form of Pembro. But what we did is that we decided to run further tests and look whether the PD-L1 or PD-L1 was present. And further studies were done on this before the decision to start on gemcitabine. Unfortunately, her PD-L1 was less than 1%. So she will not benefit from immunotherapy. So we went back to the good old drug gemcitabine, which is about 30 years old. and you know, the old things are still very, very important in cancer. Yeah.
That's really true, Doctor. So I've got a couple of questions which has come to us over some sessions, and if you're okay, I wanted to ask those questions so that we could get some answers together. First is quite a lot of people ask on whether is it necessary for everyone to kind of get a genomic screen? Should they consider a genomic screen before they actually start looking at their options for treatment in cancer? That's a big question.
Okay, as the evidence are coming now, I think it is important that we do the genomics. It's important. But as I told you, it's the cost. The cost is the one that kills the population that I see. The cost is important. So I don't like to suggest it, but for the knowledge population, like my patient who had everything and the son suggested, why don't we do genomics? Then I opened my mouth. Yes, good idea. Yes, my answer is that if I myself have cancer, I want genomics to be done. At least I will know what are the drugs that I can use and cannot use. But then remember, that patient could use Herceptin, could use the second generation Herceptin, but it didn't help her. So that is why my colleague, for example, he thinks that we have to wait longer to think about this thing more evidently. But you ask me frankly, I think genomics, if it's affordable and if the insurance companies, there are insurance companies now opening up to this idea. That's very good. You know, the newer ones, newer policies. Yeah. So I think it will be finally the way to go, Dr. Murali. The genomics of the cancer is important to guide us so that we can go into something, especially if we are talking about Tamoxifen, which is a $120 treatment, to talking to about Pembro, which is 20,000 treatment. I think the genomics is important.
have a big role to play, Doctor. True.
Yeah.
There's another question, Doctor, on is it possible to run a drug screen for patients before starting treatment as a kind of start for personalized treatment? I think this is somewhere just downstream a little bit. From
there are what do you call these companies which are doing the screening on the tumor cells and telling these are the drugs that can be used. So in genomics, we are looking at the gene level and looking for the target. But there is another part where they can look at whether adramycin can be used, or DTIC can be used. There is, but it's not available in Malaysia at the moment because it's a very intensive. I think it must be coming from places which have been running this kind of work for 20 over years because they can advise us. Yes, there are companies. I think one company sends it to US. They are asking about 25K to know the drugs as well as the the genes.
As well as the genes, so it's done concurrently. There's another question on actually, in your opinion, why do you think that the disease actually progresses despite initially being very responsive to the different treatment?
It goes back to Charles Darwin. The fittest will survive. The basic principle of survival. Our cancer cells also are not unlike human beings. They also learn to survive. They survive in hostile environment. They learn to develop resistance. And that is the very reason, of disease progression.
And really, that's the primary cause actually of disease progression. It evolves to kind of get past whatever that we're throwing at it. Doctor, there's another question on actually in terms of, and this is kind of also making its rounds quite popularly. A lot of people feel that when they get actually very disappointed when they actually test for a certain receptor and they find that, for example, Herceptin, I find that I'm not suitable, I don't express the HER2 gene and the HER2 receptor, so I'm not suitable to receive Herceptin. This actually causes a lot of people to actually lose hope and so on and so forth. So that's not actually true in many senses. So what do you feel, what is your sharing for patients?
I think that's why the single most important thing for a cancer patient is they have to develop a very, very strong mind and not worry about what is in front. And don't ask for HER2 receptor to be present because that's a bad sign. That's a bad prognosis. ER/PR, if today God says, I have to give you a breast cancer, tell me what you choose. I said, I want an ER/PR HER2 negative disease to God. That gives me the best chance of survival. But if I say, no, give me HER2, I want that is not good because Herceptin itself carries a 4% risk of heart failure, and I think whatever said and done, Dr. Murali, I think the most important factor is a holistic approach, the brains instilling hope, good nutrition, positive thinking, lots of exercise, don't listen to too many people, read the internet for authentic people giving advice. That is all they need. They shouldn't be looking at drugs.
Right.
I'm in the old school, so we will think that way. We have not many options anyway.
I think today one of the interesting things, the case studies that you showed us is actually exactly proof of that. That it's not necessary for you to really be on targeted therapy to ensure that you're doing really well on the disease as well.
Yeah.
Oh, I've got a curious question, Doctor. You were speaking to us about the non-small cell vaccine, and how has that developed? As in, after the clinical trials, is it now making its way into a larger format? Did the trials work out?
You see, the thing is like this. That trial was conducted by a Malaysian company. All right, because they had the rights to distribute the drug. But unfortunately, they changed their plan of action. They decided to take it over to Europe. Then Obama's administration had opened the doors for the Cubans. So now the trials have been done in US, but there are many patients around the world seeking for this EGF, SemaWax, flying to Cuba to get the medication. And Cuba is a country, you land there, they don't chop your passport. So you don't worry. We went to Cuba. So, you know, a lot of people go there, get their supply and go back to get the vaccines. Continuing.
Okay.
So it is not on sale yet. I'm a super supporter of the vaccine, but it has to be instituted at the time of a drug holiday or therapy at which patient doesn't need therapy to build this thing against the patient. Because I had 2 patients that were cured out of the 7 patients that had a vaccine. You know, 2 patients that were cured, yeah.
Oh, right. Okay. So that's really quite good news, especially for lung cancer, which usually has such a poor prognosis for many, many patients. There's one more question, Doctor. This, I think, is a more of a clinical question from, I think, a colleague. It says, I'm prostate cancer stage 4, have done intestine surgery about 7 months ago, PSA 54 to 24, waiting for the next appointment. I'm feeling fine for the moment, no pain at all. Bone scan shows 1 point in the prostate. Any suggestions on how to move forward? And this is really very individual.
I think the person who raised the question and done the right thing. A bilateral ocheectomy is what I would recommend, all right, as an alternative for ADT therapy, because this gives, I think the patient, bone scan shows 1 point in the prostate. I don't understand that. Is it the bone is involved or not involved? I'm not sure, okay? But I think the patient should have a follow-up with the doctor, and they should check the PSA level and also the testosterone level. If the testosterone level is undetected and the PSA level is down and the bone is not involved, just keep a watchful eyes, because it'd be interesting to know the age of the patient as well as what are the options the patient has. Because there are a lot of medication, also targeted therapies now for prostate cancer that is available. Yeah? Yeah.
Right. Okay. So that's on that question. Doctor, there is, do you think that as people discuss more and more when they're being diagnosed, should it be that they start to look at options of treatment based on whether the targeted therapies available or not? Because the reason I'm asking is, and I think you disproved this to us today in one of the case studies, but a lot of people now have this idea that, oh, I shouldn't take chemotherapy at all. Chemotherapy is really bad for me. I should immediately start on targeted therapy. Targeted therapy is the only thing, and I shouldn't take chemotherapy at all. Like, and so maybe there's some thoughts on
that's a very good question, Dr. Murali. I think the patients should seek their advice with their oncologist. Then they should look into the net and check the advice. Targeted therapy is not the answer. It's one of the options of therapy. It's just another bullet in our armamentarium. All right? Follow what the advice of the oncologist is. If the oncologist said you must take 5-FU, adrenomycin, cyclophosphamide, take that, because that is the way. Because this cancer treatment, if you are in the adjuvant setting, like my lawyer patient of mine, if she had taken the chemotherapy and the radiotherapy and taken the tamoxifen, she probably today is cured for scientific reasons. But she wanted to have a baby. She wanted to what do you call, avoid it. She wanted not to even to take something like tamoxifen because she's scared she can't get pregnant. So she landed up with this complication that she's carrying the rest of her life, even though the PET scan is clear. But so targeted therapy is not the answer. You've got to get informed decisions from your doctor, and at the same time, please read and seek advice. But don't get non-medical advisors, it can get complicated, the whole issue of it. I mean, people, there are patients who take chemotherapy. You know, I always like to tell about these two patients of mine, two ladies, husbands are unfortunately were not employed. They work as a bank teller. They have their chemotherapy on Friday and return to work on Monday, despite I'm giving them 21 days leave for the next cycle. So what does it show? It shows mind over matter. The patient is sick. I have to go to work. Otherwise, the bank is not going to pay me or children to take care. So that is the reason, I think, you know, single most reason for us to win the war against cancer for a patient is be happy and try to find a solution. Don't worry too much. Don't listen to too much advice. You know what I mean? Okay.
Yep. So, and I think that's a really important point, especially for us working in the front line who speak to patients, is to share with them perhaps that, you know, targeted therapy is not the magic bullet, neither is it not the magic bullet, but really it's ironically coming back to the whole idea of personalized cancer. You have to really use the correct options, and you've even seen, I think now you see a lot more evidence coming out with the use of targeted therapy together with how to say mainstream chemotherapy, and it seems to be much more effective than even using targeted therapy alone. So I think that the point to be taken is, rather than shutting off your mind straight away to I won't start chemo or I don't want to do radio, and then coming into this this discussion with your oncologist or your primary treating physician, what's happening is you are crippling them from and how to say, not enabling them to give you the best option to kind of deal with your cancer. I think that's a really important point that Dr. Kana has kind of shared with us, and also given us quite a few documented evidence on to kind of strengthen that point. So I'm going to just check if there's any more questions, Doctor. At this point of time, I don't really see any more questions. If there's any more questions from someone, and I'm just going to how to say, while we wait perhaps for one or two more questions, I'm just going to ask Doctor to perhaps give us 1 or 2 minutes of summary, kind of put together in like a condensed version of what you've told us today, if you could take home these points of yours.
Okay. I mean, in cancer in general, I would urge patients not to lose faith. Cancer does not mean death, because normal, healthy people like me can die tomorrow, right? So don't lose faith. That is the most important, single important thing is the mind. The mind is the one that is important, all right? Second, you have to trust your doctor. And third, you've got to seek your knowledge. And there is a lot of therapies available today in the advent of targeted therapy that making cancer a disease of chronic illness like diabetes and hypertension, rather than a disease that, you know, like a dead warren, you know. All right. So I would think that unless Dr. Murali, you have anything to add.
Yeah, there's one more question, Doctor. Yeah. And this is perhaps very relevant. What has to be done to kind of move personalized medicine forward in Malaysia, in your opinion?
Wow, that is a policy maker. I'm a single practitioner in a single hospital. I don't think I can advise on that, because there's policy matters. But those who can afford it, you know, I mean, they can talk to their oncologists and ask, because some oncologists may not want to do the genomic studies, you know, but all is because of the cost. Today, the genomic studies, it's $1,000, and we can get all this information. We don't think twice to order this test, but when it is something like 20,000, 25,000, then it becomes tough. So I think, but the way to go would be, I think, when we have a critical mass of scientists doing this kind of work in our country, then will be the way. What do you think, Dr. Murali?
Yeah, for sure, Doctor. For me, I think, for me, the sharing from you today is somehow start pushing to make genomic testing actually much more affordable, and all those components that come along to affordability. Yeah, that's really my immediate take home from.
Because one of the ways is, first of all, is to educate the insurance industry, because they are quite unreceptive on that, you know. We are quite unreceptive. But I know 2 insurance companies have already included that in the policy. I know of that because
Right.
we got it for some of them. Yeah, but this is the thing. That are the new policies. The old policies can't get it.
The old policies will never be able to support, and that one kind of note as well to the younger set of people, or even to parents who are having younger children who are now just coming out into the job sector. You need to start securing insurance as early as you can, and to make sure that the policies you buy are able to cater for to mitigate the risk of having to need these kind of treatments.
Yes,
so you need to make sure it's wide enough to cover all these things.
Just for example, just for this one, in a private hospital setting, if you have a breast cancer, the HER2 disease, you would need $250,000 policy to cover you. That is from the time of surgery to the finishing the chemo, radiotherapy, and the Herceptin. You need that kind of money. Yeah,
that kind of money. So your policies need to be able to cover that kind of width as well. So if you have not got anything much, I think we're going to be really kind today. I'm just actually going to put down the code words as well. We didn't manage to squeeze in the code word earlier. So as you know, doctor, what we do is in terms of attendance, you put up code words. MMA requires us to kind of put up those code words. And so I'm just, I mean, this is perhaps a Merdeka present. So the first code word is crab, ketam, nanda if you want the Tamil. So, and then just in line with how Doctor started today on the whole use of the word crab and cancer. And the second code word is Tamoxifen. We'll type it down as well. Please feel free to use those words, both crab and Tamoxifen, to kind of put up your attendance for your CPD points. And so as we come to close the session once again, on behalf of National Cancer Society, we'd like to thank all of you all for joining us this morning, and especially so, thank you so much, Doctor, for taking time off your busy schedule to share with us and provide us some very critically important insights and really, how to say, deep information that I think will be of a lot of benefit to all of us. Thank you so much to Nilai Medical Centre as well for kind of working together with us on this and putting this out. For those of y'all who want to re-watch the video, it's coming up on YouTube, I think in about an hour or so. And then we will share that with you so they can continue to watch, share, and kind of get your CME points. So thank you very much, Doctor, once again. Have a nice weekend.
Thank you very much, Dr. Murali. Thank you.
Okay, and thank you all. Bye-bye.
Bye.